Welcome to session 3, everyone. My name is Is that on? Yep. There we go. My name is Marcus Sellars. I'm a research fellow. I was working with Emily at the ANU for the torch work. I've since moved on from that. I'm working on a completely different project at Deakin, but it's great to be able to present these findings to you today. For torch, I'm not a health economist, so I was part of a small qualitative team, and Stacey and Joe also part of that and really helped in terms of the design and analysis and everything, so thanks to them. So yeah, with that said, I don't feel like I'm probably the least qualified person in the room to talk about QALYs, but it's relevant to this project. In terms, it's about HTA and decision making, and so I mean, you guys know this stuff that there's a limited budget and needing to make decisions, and within that framework, QALYs is a useful tool in that it measures quantity and quality of life. And the idea is that in that HTA process, you can make a judgment around value for money. Coming into this project, I sort of learned more about equality, and equality is equality is equality, and the debate around that. And is that fair? Is that the sort of a technical side of things of does that work out fair in the long run? But then there's also a moral component as well in the literature. And so this is a question we were looking at with torch. It was really about children and young people, but we did get into other areas as well. And so, I mean, the way I was sort of putting it with the public interviews, which I'm about to report, was, you know, imagine you're a decision maker, imagine you're on the committee. A submission comes in, it's really relevant to children. Do you value that higher than a submission for adults? And if yes, well, do you do it as a rule, or do you do it deliberatively? Like, how do you actually do it? So there's some of the questions we went through and I'll talk about now from interviews with the public, but also interviews with the decision makers after. Yes, so we interviewed 15, the public recruited through social media, 15 to 7 years old adults and decision makers as well, and exploring. We were looking at weighting of health gains, moral relevance of CYQ status, and other underlying principles of HTA. So the public interviews, yes, we recruited them through social media. We had a screening survey to purposefully sample. We also had a pre-information survey, and then during the interview, I actually read out a description of the decision-making process based on the interviews I just completed with the decision makers and how we understood that. In terms of representation, pretty good in terms of age and gender. Quite a good mix of health experiences there. Some people have a lot of health experience with the health service, and some with not much at all. And then in terms of, and also from across Australia, this CIFA thing down the bottom there is essentially derived from your postcode. It's a tool from the ADS. It goes from 1 to 10, and it's about socioeconomic disadvantage. So 10 is the most advantaged. And so we had a good range, but overall more advantage. So just something to note there. So in terms of the interviews with the public, it's interesting. I was kind of surprised. I wasn't really sure how they would engage with the topic, but they were very thoughtful and very interested in the topic, and they worked really hard to solve this problem, I suppose. But in doing so, they struggled to commit to a straightforward or coherent position at times. And it wasn't because they were being irrational, they didn't understand it, it's just because this is really hard. And the framing might have changed. So am I thinking about intrinsic value of a child's health gain in a child versus an adult? Am I thinking about severity? Am I thinking about, they could see the intersections, and it made it very complicated. And so there's 4 main themes here. I'm just going to focus on 2 and 3 now, just because I won't be able to get through all of these, all of the details. But this quote here is talking about, well, I'm coming from an ethical standpoint because, you know, I don't have the case in front of me. It's really all I have to work on, which is really reasonable, I thought. So this figure here was part of our analysis, and in going through the transcripts, we're thinking about this issue of moral weighting, moral relevance, numeric weighting, and we sort of try to put people into these boxes more or less, but just noting that because of the complexity, sometimes people did move around the different positions, but we're trying to colour these in a way so what was most strongly endorsed overall from within the interviews. So numeric weighting was about like specifically assigning numeric values to submissions, whereas deliberative was more of a deliberative case-by-case approach to looking at prioritisation, I suppose. And then on the left-hand side, the moral relevance of CYP status. Some factors are relevant, including CYP status, or some factors are morally relevant, should be prioritised but not CYP status. There was a potential fifth position there that would be just very egalitarian, just treat everything the same. It wasn't identified in the data. So people did see morally relevant factors that should be prioritised. And then because you see at the top there, the dark blue, that's about not supporting numeric weighting. People overall did not think that was a good idea for various reasons I'll talk about in a second. But that combined with, you'll see that 1 and 3 were kind of equally split there in terms of moral relevance of CYP status. Because of that, the fourth position there was do not weigh CYP status, either numerically or deliberatively, came out the strongest overall. So this person here is having a lot of fun with it all, but this sort of, could use a rule-based thing, it might be a better outcome, but the public probably don't like rules. Help me out. You disagree, recognizing that at the start he said something else, and now he's saying something else, and then, my view is I think we should treat children more than adults, but I don't really know why. Sort of showing the difficulty of the problem. Just some quotes here in terms of each of these positions. So those who did not, those who supported numeric weighting as a strategy to respond to the difference, really came at it mostly from socio-economic disadvantage, inequities in society, and they're aware that they exist, and this might be one way we can address that. So this person here is really across the idea of equality versus equity, and most young people were. I was surprised by that, very across these terms. Different people have different needs, we need to take that into account. And this person here is actually saying we should weight children, but mainly because of the impact on the families. So quote here for interesting that in terms of not including CYP status, but this person was saying, well, Aboriginal and Torres Strait Islanders they're morally relevant, but children aren't because they grow out of being a child. So sort of this idea of transient disadvantage, I suppose. And this one is around the CYP status is relevant because they especially around mental health care, and a few other things I'll talk about in a second. But thinking it can't be a formula, it's going to introduce biases, it's not going to work. And this final quote here around do not weigh CYP status, just looking at blanket rules and just saying they don't work. You can't always save the younger person. You need to go on a case-by-case basis to look at as many similar cases you can to get the best result. Just in terms of the other priority setting criteria that was identified, some participants talked about sort of a ladder of need, and within that they talked about other groups which either rivaled or even surpassed CYP status in what they thought should be prioritised. Within these groups, Aboriginal and Torres Strait Islanders were definitely most strongly endorsed overall. This quote here is saying, I don't think kids are the top group, but they're feeling that they're discriminated against as well as Indigenous people, but they actually ended up still putting Indigenous above young people. And interestingly, then they would say, well, but if it was a young person who was also Indigenous, then, and it gets really complicated. They also talked about intervention-related factors. So your pain medicine was one that came up a lot. Actually, some of the younger participants I interviewed had a lot of issues with this area, and particularly around not being able to access specialists. and needing to go overseas. So I don't know if it's an Australian problem here. And mental health was a huge problem across all of the interviews and accessing mental health treatment for young people. Some participants were frustrated about the focus in Western medicine on sort of treating in an emergency or chronic illness management rather than actually funding interventions that try and get in front of that as well. So I'll talk about the decision makers now and then I'll sort of compare them both if I have time. But first, so before we got onto the sort of those moral questions and the social values, we actually wanted to know how decision makers make decisions because it wasn't so clear to us on the qualitative team. So through this, we learned that they were really sort of opposed, most were opposed to sort of reductionist or algorithmic approaches and the fear that that would lead to really poor outcomes in society. And there's a strong need for a deliberative process and it needs to be flexible and holistic. And some participants did talk about they take a societal perspective when they make these decisions, but then also acknowledge that there's no real concrete definition of what that actually is. So it's a challenge for them as well. This sample here is slightly broader than the previous one. Sorry, I should have mentioned the previous slide was just about PDAC and MSAC members past and present. This is slightly broader. It has some people who were less proximal to those decisions, but eligibility is slightly broader there. So involvement in HTA, in healthcare settings regarding children and young people. We had some sort of more HTA methods experts with relevant experience and some people on the subcommittees of MSAC and PPAC as well. So the decision maker interviews, there was a strong sense of attention here around universalism and needing to maintain the rules of the game. And if we throw that out, it's a new paradigm, and that was really concerning for some people. And that's sort of aligned with that equality is equality approach. But then they identify all these issues in the middle of practical, methodological, ethical, contextual, that you need some flexibility, you need some ability to contextualize, but don't depart from the universalism. We can't, we need to start from there and then we can make adjustments afterwards. And this participant is pointing out it's actually really hard to do research in children, and participants often talked about not seeing many submissions for children at all, and maybe that's something we need to focus on in the future to incentivize industry as well. So only one participant out of this sample was on board with this idea of numeric weights for child QALYs. Most, similar to the previous study, most oppose numeric weighting generally, but also for children specifically. There was that, as I mentioned, this contextual universalism, and that's sort of versus like pure universalism or exceptionalism as well, so making exceptions for some groups and having different rules for some groups. Or just having like really rigid criteria would be a more universal approach. With the decision makers, was more a focus on that sort of middle image I have, which is around the equity of access issues and needing to improve those, rather than sort of a philosophical position that a health gain in a child is intrinsically more valuable than a health gain in an adult. They tend to talk more in that way. So I just won't be able to go through all these in detail, but it gives you a sense of some of the challenges they thought that were unique in paediatric HTA, but not always. Some of these issues come up in other conditions where capacity and communicating might be an issue. The proxy reporting was a huge issue in terms of just people having trust that that was an accurate measure. The quality of life measures were so broadly talked about as really inadequate. Welfareism and concepts around who should judge what's in the best interest of the child came up. Should it be the child? Do they have the ability to think ahead of time? Would it be the parent? Could it be the general public? Could we get certain values from society and use those to inform decisions? They also talked about when there are paediatric submissions, there was more scrutiny on the committees through the media, through advocates, through social media. So it was just something that they felt that there was a lot more pressure when it was concerning submissions to paediatrics. The discount rate was an issue at the time. I don't know if it still is, but they had a uniform discount rate, I believe, at that point. And there was just a lot of argument and discussion around that. So kind of similar to what Martin was talking about, this idea of a pragmatic solution and contextual universalism, balancing this idea we need a universal system, but does all paediatric also have these needs and issues we need to address. Participants talked about accepting greater uncertainty in paediatric submissions because of all of these issues. And that came into that, again, that equity of access, not the intrinsic value. So I think one participant talked about it like an unspoken affirmative action on the committees towards children, that we don't see a lot of these submissions. They're really hard to do, and they're a bit more flexible in the way they evaluate them. In terms of the evidence and broadening that, some participants talked about it. There's a sort of focus on RCTs and gold standard trial. This is not possible in paediatrics. It's really hard, and maybe we can consider real-world evidence, patient-reported outcomes, maybe broaden what we look at in terms of benefits and how it affects the families. And as I mentioned before, perhaps trying to incentivize industry to collect data in paediatrics and actually improve the measures. And I think some actually mentioned in the US and in Europe they do actually have incentives to do trials in children. And this last point here is just around sort of the ethical issues. So talking around testing embryos, and they have guidelines that says we should think about ethical factors, but maybe giving more structure and guidance on exactly what they are and how to include them, how to talk about them, because it would actually really help the committees. In terms of the similarities, both groups, the public and decision makers, were not in favour of rigid rules of based approaches, thresholds, those sorts of things. It was more about flexible case-by-case assessment. A range of issues in terms were raised about if we had explicit numeric weighting of QALYs, and also recognising multiple relevant factors beyond age, but might also include age, so further complicating things. This participant here I thought was interesting because they say that we could use a threshold, but maybe it's more to inform things. It could be, which my understanding is similar to what is currently done by the committees. They use the HTAs to then inform their decisions. And yes, this decision maker talking about if we're going to bring societal values in, it's really complicated. It's better to be in the bigger deliberative environment. The differences is mainly in terms of where participants were coming from, I think. So the public tended to focus more on fairness and more philosophical ideas, just given that they're not living in the committees and in that world. So that's what they were working with. And they also, maybe because of that, because they weren't looking at each individual case, they were sort of aware of their limitations and were quite happy to defer to experts. They were also really happy with the committee makeup in the way that I described it to them, and that it wasn't politicians making the decisions, and that there was HTA and there was clinicians. They thought that was great. And the decision makers there, I mean, some of them were coming more from that philosophical point, but mostly it was about this equity of access and all of these other issues that go on in the HTA system, the system gaming and concerns around, well, if we're really explicit, then industry will try and get the result, will get the funding. And the desire to incorporate public preferences into decision making. So that's sort of contrasting there. The public wants to defer to the experts, but decision makers want the public to tell them what to do. So this participant is talking about sort of recognizing the granularity of it all, and then nothing is like, it's just, okay, if I look at it all hypothetical, yeah, sure, say the young person versus the adult, if everything's exactly the same, then yes, but that doesn't happen. And this participant really talking from a very sort of technical perspective around QALYs and that theoretically they should, my mic's now, but how theoretically it should all benefit in the long run because they have longer to live, they should end up accruing those benefits anyway. Yeah, okay, so overall there's a preference for the flexible case-by-case considerations over the rigid rules. Skepticism about weighting QALYs, that based on this, the public would not agree that that would be a good idea. But some groups are relevant, morally relevant to prioritisation, and children and young people are in the mix, but rarely at the top from this study. In terms of the policy, it's a challenge. How do you incorporate these values? How do you measure them? How do you define them? And then how do you incorporate them in sort of a universal framework? And some participants were very concerned about moving away from the existing framework, that it would sort of open a Pandora's box, that it would introduce all these issues. So if we were going to incorporate societal values into every submission to make the evaluation, I think one participant compared it to Brexit. It's like if you ask the public to do that, then you've got to do it, even if you disagree with it. And then this idea of being flexible in decisions, but then how do you be consistent given the granularity of all the things that go into every single consideration of every submission? It's really complicated. And considerations for this, people talked about there could be more transparency about how less quantifiable factors influence the decisions. Could be ethical frameworks to sort of consider these sort of issues in more detail and give a bit more guidance and structure around how they should be used. A big part of it in terms of innovative approaches for capturing child and family benefits and what they look like. There's a huge amount of work to be done there, it seems. And to develop methods to incorporate broader societal impacts into pediatric HTA. So thanks. Any questions? Sorry.
I'm not sure if this is a question, but I just found it really interesting that the general public and the decision makers were so aligned in terms of the approach that they didn't want to. I would have thought the public may wish to have more of a, we know what went in and we know how that's considered every time type of approach compared to the decision makers. But that's found that really interesting.
There was a lot of trust in experts, and they know what to do, and I don't have all the details with me. Rather than most of the emphasis on the public should be doing this maybe through a jury or something like that.
Very interesting research.
Just got an observation.
Thanks,
Marcus. Really interesting how when you talk about in the data that you collected, the early data where you didn't see the egalitarian theme come through. Is that, I understood that correctly? Just noting MSAC recently made a recommendation around newborn screening and actually made an assumption about egalitarianism, and they assumed that the public would want an egalitarian approach. So I just thought it's just really, I had issues with that assumption, but it's made it into the public summary document. So it's just an interesting point to know.
No, most people sort of, there was a big focus on people really aware of social disadvantage, and not every people coming from different circumstances, and we can't treat everyone the same.
Marcus, I just thought it might be useful if I made a couple of comments from a sort of decision maker perspective, not just on your comment, but also perhaps might just get people to think differently a bit about the whole notion of measuring quality of life in kids and what that might mean to decision makers from that perspective. So simplistically, I think there are three sort of scenarios, at least that PBAC considers in relation to drugs for kids. Now, they're not distinct scenarios, but there are overlaps. But I think from a decision-making point of view, there are probably three. There are interventions with short to medium-term certainty of what are crudely called cure. There are interventions that don't cure, but where there is potentially improved quality of life, which may start fairly early, but may require the drug to be given for life. And then there are interventions that may cure, but the proof of that is likely to be determined outside of the sort of time frames which are relevant to funding decisions. So something like more than 5 to 6 years. And each of those scenarios, the implications of the questions that we're asking today about these instruments is actually different. The other thing is, and you've suggested that, and I'm sure a number of people commented on it, in that the actual considerations of medicines within PBAC for kids is a really interesting situation, because again, you have medicines there are diseases which there is a continuum across between childhood and adult, something like asthma, where the medications are basically pretty much the same across them, and in that situation, there have been scenarios where companies have sought more money for the paediatric version of the drug, but in the main, PBAC would treat those as pretty much the same issues in terms of the quality of life issues that applied across that sort of spectrum. There are diseases which are more common in kids, and then there are diseases which only occur in paediatric populations. And the challenging bit is where you've got the diseases which are present in childhood, but where there is limited information, and to extrapolate to childhood for those diseases, and you spoke about those. And then there are the specific childhood diseases, some of which are common and preventable, say in the case of some of the vaccine preventable diseases, versus the uncommon scenarios. And in some ways, those different groups have different perspectives, and the role of quality of life in making those decisions are different, and the reason why PBAC might make decisions to fund drugs might be different. And so I'm going to give the audience a couple of scenarios, and they can decide what they want to do with it. So let's pretend for a moment there's a drug for cystic fibrosis, right? It has an incremental cost effectiveness that is of about, for per QALY gained, of about $200,000 a year, right? And the studies show this drug works for a whole range of kids. But there are 300 kids who have rare forms of cystic fibrosis where the drug has never been trialled. And the company and patient groups want to extend the cover to those kids. What are you going to do? They can extend the cover. The information that you'll get from them, you'll know it's safe, but other than that, you probably know nothing about whether it's going to be effective for another 20 years.
Do you already fund it for the other?
So we funded it for the other. We've already spent, let's say, $600 million a year.
I would fund it.
You do it?
Because it's only uncertainty that's stopping you.
Yeah, well, so that's a scenario, that's a real life scenario that PBAC had to make a decision around, around that sort of scenario. Different scenario.
If they fund it.
PBAC ended up recommending that.
And you can ask the question, was that based upon the fact that there's absolutely no harm to that 300?
We're assuming there's no harm in it. probably not going to cause any harm based on the years of experience that we've had with other situations. Okay, here's another one for you. There's an inherited condition that causes very short stature, short limbs, and bone fragility. Kids usually end up in a wheelchair by the age of 10 because of the issues. It causes quite significant reductions in quality of life with a whole range of issues. There's a drug available which will enable that kid not to grow to normal length, but to increase their height probably another 50 to 60% of what they are, what they're going to acquire during that period of time. How much are you going to pay for that? First problem.
Does it address the bone fragility as well?
It stabilises the bone while they're taking it.
What do you normally pay for? What do you normally pay for? That was my first question.
Well, you know, when you say what do we normally pay, we don't have a threshold in Australia, so there's no, you know, there's no 20,000, 30,000 pound sort of threshold. We can pay whatever we like, whatever we recommend to government. They don't have to accept it.
But you must work with something. Otherwise, what's the point in doing cost-effectiveness analysis?
So exactly, that's the point. Is that that these things have a rubberiness around them. I mean, in this case, you know, the costs per QALY was probably over $1 million for each of those children. Did it have an impact on quality of life? Well, as one of the parents described to me, the difference was that that child was possibly able to wipe their bottom when they were fully grown, which they can't do frequently as a problem. They require maintenance, they require ongoing care in that regard. Now to me and to PBAC, those sorts of characteristics of the improvement in quality of life were overwhelming in terms of any measured factor that in relation to it. And I guess the point I'm just trying to make in those couple of scenarios, which are relatively recent scenarios, is that with these instruments, and that's why I was sort of asking those questions about the particular items, etc., is that the context of the decision will determine the importance of the type of information that is going to be important for it, which is why I'm sure most members of the PBAC would have said don't put a numeric value on it, because you would not necessarily have captured all those different elements even if you got to measure it within that context. Sorry, that's a long-winded answer. A long-winded question, comment.
Yeah, no, and in that first paper, actually, there was sorry, the other ones did as well, but okay. Yeah, in the first paper, they talked about needing to collect other outcomes that were important to patients in a more systematic way, and having encouragement for the sponsors to do that. Because, as you say, sometimes the QALYs don't capture it. There's things that happen that you would never expect, but that actually are beneficial.
Yeah, and I quickly add, my comment should not be interpreted as saying I don't think the work that's being done around trying to find some standard measures in this place for children's standard is not important. It is very, very important, but its importance will depend on the type of issue that you're looking at within this paediatric population.
Actually, this is Andrew, but don't they apply to adults as well?
It comes up less frequently in adults as an issue. It does come up, and there have been scenarios where I'm just trying to think of one offhand where those sorts of some particular aspects of the quality of life quality of life improvement have been important. It comes up much more. It's a harder decision area than the issues around life extension or life expectancy in some ways. Joe might remember, or Kirsten might remember a specific adult example. It comes up more commonly in sort of paediatric situations. Yeah, and we have really pushed the envelope to answer your question on what's cost effective with some of our decisions in recent times around that. I mean, you know, it's widely quoted in the literature that our sort of our threshold is somewhere around 50 to 60,000 per QALY. But if you actually look at that as a distribution, what you see is this long tail which has developed in recent times around some of the decisions we've made where, yeah, they've been cost-effective decisions which are essentially not really cost-effective decisions.
I think one sort of jump off the two things that came up. One, I remember one of the decision makers talking about the flavour of a treatment. This is dead too. The flavour of a treatment, and they're sort of reflected, oh my God, they have to take this for the rest of their life, and sort of they're looking at this bigger picture of the context and whether the intervention's feasible. Like, are there specialists that can even deliver this? Another thing that would come up would be around families, so it may not be cost effective from a quality of life, length of life, but it's open the window here for the family to have some really meaningful time with the child. It just made me think of those examples.
I can't think of examples where we've accepted that it would prolong life and allow the family more time with their child because it extended their life for a year. I can think of examples where we've said the value of one of the values in this medicine is that it improves the interaction, the family interaction. So, for example, in attention deficit disorder, for example, a consideration was beyond the child, was the interaction of child with the family. So there are situations where we look beyond the benefits to the child and to the benefit of at least the family